Good morning, good day, good evening. Thank you for joining us in this session on redefining prophylaxis. And will be a presenter and a moderator for this session. Just to remind you that regular intravenous infusion of clotting factor concentrate to increase plasma levels in order to prevent the bleed is the standard definition of prophylaxis that was published by Victor Blanchette and colleagues in 2014. Today, a number of novel hemostatic products are available or being developed, many of which are not given intravenously, are not factor 8 or factor 9, and do not increase the plasma factor level. There is therefore a need for us to redefine prophylaxis, which is what we are going to do in this session. Lined up in this session, I've got a number of international experts on prophylaxis. Victor Blanchette from Canada, Robert Klamroth from Germany, and Emna from Tunisia. In the interest of time, and I'm fully aware that we've started a couple of seconds late, I'm not going to read their impressive bios. Without much ado, I would like to invite Victor Blanchette to do his presentation on defining successful prophylaxis. The paradigm is changing. Over to you, Victor.
Welcome to everyone, and I'm delighted to participate in this WFH virtual symposium. I am Victor Blanchette, a staff hematologist at the Hospital for Sick Children, Toronto, and I'm talking to you from home as we are all in lockdown here because of COVID-19. Shown on this next slide is my disclosures. And on the next slide, I will start, this is the presentation outline with some definitions. I will then talk briefly about the history of prophylaxis, prophylaxis in the era of new therapies, outcome measures, and we'll close with a summary. Now, if one looks at the Concise Oxford Dictionary, 7th edition, success is defined as a favorable outcome or accomplishment of what was aimed at. You have to have targets. I will get to that later in the presentation. Prophylaxis is defined as preventative treatment against disease. So, for example, when one gives factor therapy in anticipation of surgery, this would be a form of very short-term prophylaxis. And prophylactic is a course of action tending to prevent disease or other malfunction. Now I will move to the next slide, which is concentrating more on prophylaxis in the context of musculoskeletal disease in persons with hemophilia. In 2003, I was privileged to be part of a consensus conference in London chaired by Eric Bernthorpe, and at that time, one only had safe virus inactivated concentrates or recombinant concentrates, and the definition of prophylaxis was the regular replacement of the missing clotting factor given in anticipation of and with the intent to prevent bleeding in persons with hemophilia. Of course, in this era of novel plasma-derived products, the extended half-life products, the important non-factor products you're going to hear more about, this definition had to be revised, and in publication by Manuel Carqueo recently, a new definition was proposed, which is the regular administration of a hemostatic agent or agents that safely, effectively, and conveniently prevent bleeding while allowing persons with hemophilia to lead active lives. Now, I was, in the next slide is listed the definitions from the International Society on Thrombosis and Hemostasis regarding prophylaxis in the context of musculoskeletal disease and arthropathy in persons with hemophilia. I was privileged to lead this project group, and you can see on the left that the types of prophylaxis are primary, secondary, tertiary, and intermittent or periodic. Primary prophylaxis was defined as the regular, continuous replacement therapy started in the absence of documented joint disease, determined by physical examination and or imaging studies, and before the second clinically evident joint bleed or age 3 years. And continuous was the intent to treat for 52 weeks with a minimum of 45 weeks. Secondary prophylaxis was therapy started after 2 or more joint bleeds but before the onset of joint disease, documented by physical examination and or imaging studies. And tertiary prophylaxis, the type of prophylaxis that would be given to persons with inhibitors, bad joint disease, was therapy started after the onset of joint disease, documented by physical examination and plain radiographs of the index joints. Whereas intermittent prophylaxis was prophylaxis for periods not exceeding 45 weeks per year. Now, if we go to this next slide, this is the history of prophylaxis spanning 50 years, and shown in this monograph from Malmberg is data from the Swedish Malmo Hemophilia Treatment Center, and this group was led by the late Ingram Marie Nielsen, and what the investigators did is they cataloged and characterized all persons with hemophilia in the country of Sweden, about 7 million. They could measure factor levels very well and could categorize patients as having severe, moderate, or mild disease based on baseline factor levels. They were able to do joint scores, and what that showed at a time before prophylaxis was really started was very early, is that there was a significant burden of musculoskeletal disease, as you can see in the plain radiographs and the evident arthropathy in the boy to the right. An important observation from this study was that arthropathy was rarely seen when the baseline factor was 3% or higher. And that led to the gold standard Malmo prophylaxis, summarized on this slide, the gold standard, which is replacement therapy for persons with hemophilia A, giving factor 8 between 25 to 40 international units per kilogram on alternate days, minimum 3 times a week, and for hemophilia B, twice weekly with the same dose. The goal of this Malmo protocol was to keep factor levels at 1% or slightly higher. Now, this next slide depicts some findings reported in 2 publications from Peter Collins in Wales and related to detailed analysis of the pre-licensure data for children and adults with a standard half-life recombinant product, Advate, and really challenged the 1% threshold. So what Dr. Collins reported in those papers is that the important thing was the increasing time with a low factor level below 1% for risk of bleeding, although there were some individuals with less than 1% who did not bleed and those with more than 1% who did bleed. He also stressed in those papers, as had the Malmo group, Professor Nielsen, that adherence was critical. If you do not adhere to the prophylaxis regimen, the outcome is definitely not going to be good. And we now have long-term data from countries where prophylaxis was started in primary prophylaxis at an early age in the 70s. And this data on this slide from Professor Oldenburg in the Bonn Clinic showed the data over a 30-year span in young adults where the objective measures of joint scores using the Gilbert score and the plain radiograph index joint score, the Pedersen score, are depicted. And you can see in the 2 circles in red that it is the ankles that contribute most to arthropathy in programs of prophylaxis started early, and this has been found in subsequent studies. And in this next slide, you will see that there are multiple risk factors for bleeding. in persons with hemophilia. Some are host-related, such as the severity of hemophilia. Persons with severe hemophilia with factor levels less than 1% bleed more than moderate or mild, and the time spent below a critical threshold is crucial for risk of bleeding. The pharmacokinetic profile of patients following infusion of factor 8 or 9 is very important, and we know in factor 8 this can vary between 2 to 4-fold in individuals. The underlying status of joints at the time of prophylaxis is important, and individuals with target joints frequently bleeding are more prone to bleeding. The activity profile of the individuals is also important, and the nice data from Australia in a cohort of boys given prophylaxis showed that there was an independent risk factor for high-intensity sport with regard to bleeding. Now, shown on this schematic slide is the complex coagulation system with both the procoagulant and anticoagulant pathways. You are going to see and hear more about this, particularly in the context of rebalanced hemostasis and the manipulation of the anticoagulant pathway with agents such as the bispecific antibodies, emicizumab, the anti-TFPI or tissue factor pathway inhibitors, and the antithrombin knockdown product fitusiran. And as we meet today, we are in an exciting era in the past few years of treatment for persons with hemophilia with a wide array of therapeutic products depicted on this slide. And depending on where you are in the world and access, you might be able to use either plasma-derived virus inactivated safe factor 8 or 9 concentrates or recombinant concentrates or designer extended half-life concentrates. We are excited about the breakthrough that uncouples von Willebrand factor to factor 8, such that with the BIV 001 product in advanced clinical trial, we're looking forward to a factor 8 that can be given with a half-life of 35, 36 hours. Of course, the non-factor hemostatic agents, you're going to hear more about those, are very important. As I said, the bispecific antibody, the antithrombin knockdown, and the anti-TFPI antibodies. And the final goal is normalization, which is gene therapy, and the trials with gene therapy are, as you know, very promising and exciting now, not only for factor 9, but also for factor 8. Shown on this next slide is a publication by Alfonso Aori in Hemophilia in 2017, in which a Delphi consensus initiative looked at target factor levels for various scenarios. And over on the far right, you can see some of those scenarios depicted. So, for example, with major trauma or surgery, one would be aiming for normal factor levels in the range of 80 to 150%. If you go to the bottom right, you will see that in children that are very young, or perhaps in older, more sedentary patients, less than 1% might be okay. And in the middle of the slide is the interplay of physical activity. So high-impact physical activity will need higher levels to protect against bleeding, where intensive sport activity would be less. And the next slide is just a schema of what is increasingly promoted, which is individualized prophylaxis as a way forward. You can see PK curve shown following infusion of factor 8, and peak levels, trough levels, and under that curve is the area under the curve. So if you look at the pictures in the far right corner, you can see little cartoons. So if in Canada we have 4 seasons and downhill skiing would be a very risky sport, we don't promote it. But if you were going to do that with proper equipment, you would certainly want higher levels. Whereas with soccer, which is very popular worldwide, you would certainly during intense soccer playing and games might need higher levels, where in toddlers and older persons who are sedentary, perhaps lower levels. Now, all of these therapies, although very exciting, are very expensive, and we need increasingly outcome measures that are required by regulatory agencies and funders. And a focus has been on patient-reported outcome measures, some depicted on this slide, and they include things such as the self-proxy reported bleeding events, acute joint bleeds, target joints, quality of life questionnaires, which can be either generic, such as the EQ5D, or disease-specific, the Canadian Chocolate Tool, the European Hemoqual tools, activity questionnaires developed by the Dutch group in Utrecht, the Hemophilia Activities List, or the pediatric component. And I draw your attention to the Patient's Reported Outcome Burdens and Experiences tool that has been developed by Mark Skinner and colleagues and is an important tool in this area. Now, definitions are important. I go back to the ISTH definitions, and in that publication, there are definitions of acute joint bleed, rebleed, target joints, resolved target joints, and I just show one here, which is the clinical features of an acute hemarthrosis or joint bleed. The patient often feels an aura, pain, swelling, warmth, decreased range of motion, or loss of function. I might add that in very young children, it can be sometimes quite hard to know if there is really an index joint bleed acute, and so some of the data is not absolute in that regard. And the next slide is other outcome measures that are objectively determined, and these include functional joint scores. The group in Vellore, India, headed by Professor Alok Srivastava and his excellent team, have developed the FISH for adults and a modified eFISH to pick up earlier disease. The Hemophilia Joint Health Score, developed by investigators in the Joint Health Group of the International Prophylaxis Study Group, has validated a tool that is now replaced the Gilbert score because it is sensitive to earlier disease, and of course, importantly, imaging scores derived from plain radiographs, ultrasound point of care or full diagnostic, and magnetic resonance imaging. And in this next summary slide, I think we want as our goal to have persons with hemophilia normalized to lead normal lives, and you can see here the definition of from the World Health Organization with regard to quality of life, and it's very much related to the individual, their goals, expectations, standards, and culturally very different. Shown in the center of the slide is chocolate scores. They range from 0 to 100. 100 is best for many countries, and the average score in the European countries and North America, where prophylaxis is available, is very good, approximately 80 or above, whereas if you go to other countries where access is more limited, and shown here are work we did in Brazil, China, Jamaica, and the Ivory Coast, the scores get much lower. And as an extreme example, in Jamaica and the Ivory Coast, where patients are often not diagnosed or have only access to plasma or cryoprecipitate, the scores are extremely low. So this is a good thermometer of well-being, and these scores are important as we go forward. Now, probably the best way to achieve what we want is through a shared decision-making approach in which the patient or family for young children is at the center. The multidisciplinary hemophilia care team, I can't stress that enough, and this interaction where the team goes over with the patients or the family benefits, risk, and alternatives, and in an iterative process arrives at what is best for that individual, and that of course varies across the age span, varies from country to country, and is an increasingly promoted and used model with very good results as the patients feel the center of attention. And I leave you with the cartoon that every bleed matters. We know that just a few bleeds can lead to target joint bleeding and destruction, arthropathy, and we should do everything we can to prevent bleeds, and most importantly, if there are breakthrough bleeds, to treat those bleeds effectively with replacement therapy and with rehabilitation using an expert multidisciplinary team such as physiotherapists. And finally, I do want to thank a number of collaborators worldwide who've contributed to our knowledge about prophylaxis, starting with Professor Nielsen and the group in Malmo, Sweden, and then, of course, the Dutch with their intermediate dose prophylaxis, the Italian study, their SPREE study, and we all know about the very important randomized control trial from the joint outcome study with Professor Manko Johnson and her colleagues. We have recently published the final results of our Canadian dose escalation study that went over 10 years in young boys, and of course the emerging prophylaxis data from resource-constrained countries such as China, India, Indonesia, and Tunisia. You're going to hear some very nice data from Professor Gouider later in the presentation. I thank you for your attention and hope you all are keeping well and have a good day.
So, hi everyone. I'm Robert Klamroth from Germany, and I will start now my presentation. Here are my disclosures. You see there's a lot of involvement from different pharma companies. This is mainly due to studies and other things. So I want to continue where Victor stopped. And I cannot advance my slides. I'm sorry for this. So prophylaxis is a treatment of choice. And we all benefit from prophylaxis started early in patients with severe hemophilia, and that is well demonstrated. And in Germany, we are lucky because our authorities recommend prophylaxis for all patients with severe hemophilia. There was a rapid report in these times, and we have the suggestion that all patients should be treated, that the goal is no bleeds at all. There is variability, and Victor told us already, in the phenotype, bleeding pattern, and in the individual response to replacement therapy. And guiding our patients to the optimal prophylactic treatment in daily life is of major importance. Do we have any, next slide please, do we have any evidence that a higher trough level is beneficial for our patients? And if you look at this graph, and it's very often cited, the famous Dutch study about patients with different severities of hemophilia, you see there's clearly a close relation between the residual activity and the bleeding tendency in these patients. And maybe a factor level above 10% will make a bleed-free world for all patients if we can achieve this. The second point is in the next slide that our definition of hemophilia is according to factor level. And replacing the missing factor, we can achieve mild, moderate, and normal factor levels with replacement treatment. And if this is true, that it's very clear that the higher level of the missing clotting factor, like factor 8, have a better protection. Of course, in the next slide, you see that personalized prophylaxis is an individualized treatment. And what we did now, that we changed patients to moderate patients, and that's a slide Victor showed before, that we have still joint disease. So what we did over 30 years with a long-term prophylactic experience in Germany, it led still to joint disease, and maybe we should go further with higher trough levels. And the trough level of above 1% in the personalized way of prophylaxis is not enough. And I want to guide you now through the PROPEL study. In the next slide. Now, this is my idea of personalized prophylaxis, where you have multiple different tasks. And trough level is only one task in this, but of course an important task. And of course, we have to keep it individually for every patient in this treatment. And now I would like, do we have some evidence from the studies that a higher trough level results in less bleeding for our patients? And then I want to share with you the results of the PROPEL study. In the next slide, please. The aim of the PROPEL study, and I'm referring now to my presentation on ISDH last year, because the main manuscript is still under review for publication. So the idea of the PROPEL study was in a randomized, controlled phase 3 open-label multi-center trial to evaluate the impact of higher trough levels for our patients. And we compared in the safety and efficacy of a PK-guided treatment with an extended half-life factor VIII in two groups with factor VIII trough levels of 1 to 3% and 8 to 12%. And the idea was that patients with a higher trough level have more patients in the group with 0 bleeds. If you look now at the objectives of the study, if you look now at the distribution of the study in the next slide, you can see that inclusion criteria were patients with severe hemophilia A at the age from 12 to 65. They had to have a severe bleeding phenotype before because the ABR have to be above 2. Of course, there was no inhibitor present at the inclusion of the study, and all patients went through a PK study. And after the PK study, there was a randomization to the high dose group, targeting a trough level of 1 to 3%, and to the high dose group, targeting a trough level of about 10%. There was a 6-month run-in period where this was adjusted, and then there was a 6-month evaluation period where the main goals of the study were evaluated. Keep in mind that patients were randomized in the two treatment arms irrespective of individual characteristics like half-life, activity level, or the bleeding phenotype. That was a clear recommendation. The next slide, you see the goals of the study. So the primary efficacy was a proportion of patients who received a total ABR of 0 in the two prophylactic treatment arms in the 6-month study period. And the secondary efficacy was assess the proportion of patients who achieved a spontaneous ABR of 0 in the 6-month period. And we had the usual safety evaluation of adverse inhibitors and especially of inhibitors. If we go to the next slide, you see the patient distribution. We had 2 for the outcome. It's important to remind you that we had a primary and a secondary efficacy outcome, because in the full analysis set, all patients were included. Of course, you can imagine in such a study that not all patients comply with the protocol, and there's a second analysis set where patients per protocol were analyzed. If you look here now at the distribution of the patients in the study, in the next slide, there were 135 patients screened. There were some screen failures. There were, in the end, patients randomized, 118 and 57 in the low dose group and 58 in the high dose group. Keep in mind that, of course, we had some dropouts in the study. And you see here already that more patients in the high dose group dropped out, and there were several reasons, but some reasons were not to comply with the protocol, maybe due to the high burden of treatment. In the next slide, we see the different patients. You see in both groups, it was pretty well distributed. Patients were on the same age, and there were all patients with a number of target joints, so more than 70% in both groups had a target joint. And the only difference that maybe in the high dose group, the number of target joints were a little bit higher. If we now look at the results in the next slide, you see that in the patients in the full analysis set, there was a difference that patients had a lower total ABR, a lower spontaneous ABR, and a lower spontaneous joint ABR. And if you look at the mean values, there was the ABR, total ABR of 3.6 in the low dose group and 1.6 in the high dose group. If we look now in the next slide on the patients who complied fully with the protocol, you see these results were statistically significant. There were a clear difference for total ABR, spontaneous ABR, and spontaneous joint ABR in these patients with very low levels in the patients with the high dose group. Did we reach what we want in this study with the protocols? On the next slide, you can see that the calculation of half-life and the individualized prophylaxis resulted to very good results concerning the trough levels in both groups. So you see here over time that the factor VIII trough level in the low dose group was clearly between 1 to 3% over the whole study period, and the same was true for the factor VIII trough level in the high dose group, maybe a little bit higher in the beginning, but then exactly what we wanted to reach. So how many effort did we have to do with the product to reach this? In the next slide, you see the evaluation of what we did. And first you see, of course, if you want to go for a higher factor VIII trough level, you have to inject more. So the number of prophylactic infusions per week was about 2.5 or 2.3 in the low dose group and 3.6, so between 3 and 4 per week in the high dose group. And that results in a higher amount of IV injections per year. And you see that the dose, the yearly dose in the low dose group was about 4,000 units per kilogram body weight per year and about 7,500 per kilogram body weight per year in the high dose group. But what is interesting and needs further analysis, there was an overlap in both groups. So you see there's a huge variation in pharmacokinetic in our patients, which make it really reliable to dose due to pharmacokinetic ways. Did we have any adverse events? Please go to the next slide. In the next slide, we see the adverse events in the study. Next slide, please. And there was no deaths, no thromboembolic events, no severe allergic reactions, and no adverse events that led to discontinuation. There was one patient in the high dose arm who had a serious adverse event related to the product in the study. This patient was tested for inhibitors one time positive with 0.6 Bethesda units at week 8, but all following inhibitor tests were negative. There were no anti-factor VIII binding antibodies, and there was no impact on PK, so it might be a laboratory error. So what can we conclude out of the PROPEL study? And that is my last slide now. Please go to the last slide. So targeting factor VIII trough levels about 10% versus the usual prophylactic treatment with 1 to 3% resulted in a consistently lower total ABR and a higher proportion of patients with zero bleeds. I think there's no difference in safety. So yes, we can give more factor VIII to the patients, and an individualized protective factor VIII level for some patients results in a much lower bleeding tendency. So I think the results of the PROPEL study, it's the first randomized controlled trial, this emphasized first the importance of a personalized treatment for patients with hemophilia A, and second, that with a higher trough level, we can achieve in more patients zero bleeds. And in the future, with factor VIII products with an even longer half-life, maybe this concept will be much easier with a less burden of treatment of frequent injections. So I hope I made the point clear that in countries with high resources, aiming for a higher trough is reasonable. Thank you very much for listening.
Thank you, Robert. I'm going to do the next presentation, which is targeting steady-state hemostasis. These are my disclosures. What I'm going to do in the next few minutes, I'm going to address the question of why is steady-state important, what is steady-state hemostasis, and what are some of the steady-state hemostatic approaches that have been undertaken, and I'll conclude with the concluding remarks. This particular graph is actually taken from the recent publication by Mark Skinner. On the x-axis, it shows the level of protection, and on the y-axis, it shows the outcomes on the left from the patient perspective, and on the right from the clinical perspective. What is quite clear is that the starting point is that we are preventing patients from dying. And the end point in ultimately looking after patients optimally is normal hemostasis as characterized by optimized health and well-being. It is this normal hemostasis that I would like to believe is what we're aiming for when we talk about steady-state hemostasis. Just to remind you, this is an oversimplified diagram of hemostasis, just showing the procoagulant proteins and the anticoagulant proteins. And on the left, in a normal setting where you've got a balanced view of the procoagulants and the anticoagulants, the patients neither bleed nor clot, and this is a normal state. In patients with hemophilia who lack one or more of the procoagulant protein, the balance is towards bleeding. And our approach to date have been to replace the missing protein in that setting. And the way we've done it is following a number of therapeutic replacement strategies. Firstly, starting with standard half-life clotting factor, given on a regular basis. Shown on the left, you'll see that in fact you do achieve some kind of hemostasis, but that hemostasis has troughs and peaks for both extended half-life products and standard half-life products. If one looks at some of the shortcomings of this approach, the most important one is that the troughs in particular are associated with breakthrough bleeds. These breakthrough bleeds were first characterized by the Manco-Johnson study, which showed clearly that clinically not detectable hemorrhage may well be present when one looks at the MRI score shown in this diagram. A number of patients who could not recall bleeding had a deteriorating joint score indicative of bleeding. That has been confirmed by a number of other studies, such as this study showing 26% of joints that have never bled, showing hemosiderin deposit in the joint, and many others. So the concept of subclinical bleeding, even in the setting where patients are thought not to have bled, is real. And I would like to believe that, in fact, it is one of the shortcomings of the replacement therapies. If one looks at the consequence of this subclinical bleed, you do get joint damage. In the recent Thunder study, you can see on your left, not unexpectedly, that patients on on-demand treatment will tend to bleed more than those on prophylaxis. But nevertheless, even those on prophylaxis actually do have bleeds, and it is those bleeds that we're worried about. The diagram from the same study on your right compares severe and moderate patients, and I want you to focus on your far right, where patients are on prophylaxis. You can see that there is no difference between the median joint health score of those patients with severe hemophilia when compared to those of moderate hemophilia. Essentially meaning that you do get joint damage, even if you move patients from a severe phenotype to a moderate phenotype. What it also means then is that when we focus only on procoagulant factor replacement, we might not actually have patients with healthy joints. And it is in this context that we started to examine the anticoagulant arm of hemostasis. There is now a number of studies that have been undertaken to explore this. These are the so-called non-factor replacement therapies. In this model, you can see that they may well give rise to steady hemostasis, but there is no detectable level of factor that we're able to measure, which is of course not a problem as long as there is no bleeding associated with that. So in this regard, we have progressed quite dramatically. To date, there are at least 3 categories of non-factor therapies that have been developed to achieve steady-state hemostasis. They include the anti-TFPI, the antithrombin 3 RNAi, and the bispecific monoclonal antibodies. And in the last column of this table, you'll see the status of their development. Both the anti-TFPI and antithrombin have completed phase 1, 2, and they are currently undergoing phase 3, whereas the bispecific antibody has completed a number of phase 3 studies. And what did the steady state look like in these various antibodies? So if one looks at the anti-TFPI developed by Pfizer, the mastazimab, you can see that in the data that we presented at ISTH 2019, that following the build-up, one is able to maintain a certain level of hemostasis as well as a steady state drug level at various doses. The summary of this, of course, is that one is able to use this drug subcutaneously to hemostatically manage patients with hemophilia A and B with or without inhibitors. And that is probably the most important outcome of maintaining such a hemostatic level. If one looks at the pharmacokinetics of concizumab, the study of which is currently ongoing, and I'm showing you here the earlier data from the phase 1 study between a comparison between healthy volunteers and patients with hemophilia, you'll see that they are able to maintain a steady level of free TFPI over time, provided obviously they continue to receive a regular dose of concizumab. And of course, this has now been taken into phase 3, as you know. What about the emicizumab pharmacokinetics? They are also showing a similar pattern whereby a number of these phase 3 studies show almost identical pharmacokinetics shown in this diagram with the various dosing regimens ranging from weekly to every 2 weeks and once a month. The level of emicizumab following the loading dose seem to be identical, again attesting to the fact that steady state is possible with the emicizumab products. I think the most important question we should be asking ourselves is, it is all very well to achieve steady state pharmacokinetics. What is the impact of this on the bleeding phenotype? And of course, we do have data from the emicizumab phase 3 studies, and I've summarized this in the 4 studies that have been completed. As you can see, that for each of these studies, it would seem that the mean ABR is improving over time. Not only does it start at a slightly higher level, but over time, when the patients are on the same dose, it would seem that in fact the ABR seem to be coming down. So one would interpret this as meaning that if you are able to establish and maintain a steady state hemostatic level, it is possible to also achieve a very low bleed rate in the majority of the patients. If we switch away now from the non-factor therapy steady state to what the gene therapy steady state could mean in the context of our patients. And I'm going to give you at least 2 examples here of some of the study results. This is the first study from the SPARC 9001 study, in which all patients received the same dose, 5E11 vector genomes per kilogram. You will see that the graphs are individual patients, and you'll appreciate that per individual patient, once the patient has established hemostasis, it would seem that in fact they are able to maintain steady state. And of course, notwithstanding the fact that there is large variability between the patients, but that's not the point that this graph is trying to show. I think the graph is trying to show that there is steady state within the patient with at least some of the gene therapy program. In fact, if one looks at a different product, the BioMarin gene therapy, this is now a 3-year follow-up. You will see a similar pattern where in this graph we're showing the factor 8 level measured by 2 different assays. And in fact, following a year, there seemed to be a steady level of factor 8 achieved following this gene therapy. So the overall message with the gene therapy is that it is possible to achieve a factor level which is at a steady state. And the question then is, what is the impact of that factor level? And in this table, I try to summarize all of the published gene therapy studies. You can see here that in fact, the ABR reduction is consistently high across all the studies, ranging from 70% to 100%. As a result of that, the effector usage shown in the bottom line is also consistently, reduction is consistently low. You can see from 90% to 100%. So the impact, in fact, is huge for maintaining, establishing and maintaining steady state. What I hope I've convinced you is that steady state hemostasis should ideally be the target for optimal care of patients with hemophilia. And in fact, it grows across the various therapeutic modalities that we are currently either developing or currently already using. To date, the strategy of using just procoagulant activity, we know that it has its own limitation in the sense that it has a number of clinical unmet needs, which I've outlined. The evolution of the therapies towards anticoagulant approaches, we hope that, in fact, together with gene therapy, we are able to achieve and maintain better steady state hemostasis. It is in this context that, in fact, we should be able to address the unmet needs that I've already outlined. Thank you for your attention.
For making this virtual summit a reality. So my talk from Tunisia will be on low-dose prophylaxis. I have no disclosure with this presentation. We all know the vision of the World Federation of Hemophilia, which is treatment for all, and we also know that prophylaxis is the gold standard treatment. But we also know that access to treatment in all over the world is not equal, and we also know that there is cost issue with the prophylactic treatment. So there is a big gap between the different regions in all the world. So I will come back quickly to the history of prophylaxis. Then we will discuss the rationale for starting low-dose prophylaxis. We will share the published data on low-dose prophylaxis during these 10 late years, and then we will conclude. So prophylaxis was born from the observation that milder form bleed less than severe one. And the goal of prophylaxis was to transform severe form to milder form in order to reduce joint bleed and maybe prevent joint disease. The first experiences with prophylaxis were a small cohort. First of them came from Sweden, then Netherlands, then some cohorts from Europe and North America. In 1992 and 1994, we had a larger cohort, and the conclusion was that prophylaxis is superior to on-demand therapy. It's only in 2007 that the first randomized study was published by Manko Janssen. And since this time, prophylaxis was considered as the gold standard treatment, and many improvements in the different regimen of prophylaxis was made. We observed the birth of the concept of primary prophylaxis, then the individualized protocol, the higher flow level, and so on. But we know that with prophylaxis, we will need more clotting factor concentrate, so a higher cost. And what is the solution for countries with limited resources and emerging countries? Is low-dose prophylaxis an alternative? What is the rationale for that? First of all, the World Federation of Hemophilia, in its second edition of Guidelines for Management of Hemophilia, but also in the latest one that was presented yesterday, recommend to use low-dose prophylaxis in countries where there is a greater constraints on supply of factor concentrate. According to Alok Srivastava, if we consider the minimum target established by the World Federation of Hemophilia for countries to have optimal survival for hemophilia, 1 unit per capita, and if we know that in the majority of this country, only 50% of people with hemophilia have been identified, then in reality, the availability of clotting factor concentrate is the double. And so this must push people to start as early as possible with a low-dose prophylaxis, even if we are below 1 unit per capita. And finally, if we come back to the first reported experience with prophylaxis, the doses that were used at this time correspond to the low-dose prophylaxis. So let's see together now the published data during these 10 late years on low-dose prophylaxis. In 2011, China published the first study on low-dose prophylaxis, and after this study, they published almost 10 studies on low-dose prophylaxis. India also published some papers on low-dose prophylaxis, Tunisia, Thailand, Indonesia, and you have also data from Iraq. So let's start to see the first published in China on low-dose prophylaxis. It was a pilot study on which there was 34 people with hemophilia analyzable. It was a 12-week observation study followed by 12-week low-dose prophylaxis. And in this study, they demonstrated even in severe and moderate hemophilia, that with prophylaxis there is a reduction of the frequency of joint bleeds. They also observed an improvement in joint clinical function, which was measured by the Gilbert score, an improvement of quality of life with a reduction of a day absent from school. India, a randomized study on very low dose factor 8 was published in 2016 by Verma. It was a randomized study with 2 arms, a prophylactic group compared to episodic treatment. And in this study also, they were able to demonstrate a reduction of a bleeding event, of a bleeding joint with low dose prophylaxis with a significant difference between the number of bleeding on prophylaxis over episodic treatment, but there was no difference in the amount of factor 8 consumption. After, in 2017, a real-life study from Tunisia was published. It concerned a larger cohort of 55 children with hemophilia, with a median follow-up of 5 years, varying from 1 year to 9 years. And again, in this cohort of 55 children on low-dose prophylaxis, a statistical significant difference in the number of bleeding events compared to before starting prophylaxis. In this study also, the joint clinical states was evaluated by the Hemophilia Joint Health Score. In Thailand now, Thailand published first a small cohort of 6 people with hemophilia in 1995 on low-dose prophylaxis, and later now they published a larger cohort of 50 people with hemophilia with a median age of 20 years. It was a 3-month prophylaxis period. Half of the cohort didn't experience bleed, whereas the other half experienced some bleed, and it was observed that patients with target joints tended to exhibit more bleeding episodes compared to those without. Indonesia, they ran a randomized 12-month low-dose prophylaxis study in a cohort of 50 children with 2-arm prophylaxis group and demand therapy, and they also found a significant statistical difference between the different bleeding events, even the joint bleeds and the non-joint bleeds. So if we summarize this 5 study, the median dose used in those study was varying from 8 to 15 units per kg twice or 3 times a week, and they all conclude to a reduction of a bleeding event with a low dose prophylaxis. But we have to emphasize and to highlight that if we want to start it with a low-dose prophylaxis and to maintain this low-dose prophylaxis, the concept of the Hemophilia Treatment Center and the multidisciplinary care is mandatory with a regular supply of clotting factor concentrate. It's very important to understand how prophylaxis, and in this case, the low-dose prophylaxis work in order to educate parents and people with hemophilia and to explain that this is a protocol of prophylaxis, but it's not the standard dose prophylaxis. We must use outcome assessment in order to demonstrate the efficacy. So we need regular follow-up visit, evaluation of joint states. We need to document any complication and record any bleeding episode occurring during prophylaxis. And at last but not least, a very nice study. It's a model-based evaluation on low-dose factor VIII prophylaxis in hemophilia that was published in 2019. In this study, it was demonstrated that we can have a decrease of the cost with low-dose prophylaxis compared to the standard high-dose prophylaxis at a small increase in bleeding risk. It was also demonstrated in this model that it's better to have a 3 injection regimen even with a low-dose prophylaxis than 2. And the conclusion of this nice paper was that the results indicate that low-dose prophylaxis is advocated where the standard of care is on-demand treatment. However, the results should be considered in the context of any limitation of the applied model. So to conclude, what can we see on low-dose prophylaxis? Low-dose prophylaxis is cost-effective, it is efficient, it's a safe method, and we can prevent joint bleed and at least delay the joint damage with a low-dose prophylaxis. We don't have enough long-term data today, and we should carefully document basic outcome data for as long as possible. Main goals are improvement of quality of life and reduction of bleeding event rather than zero bleed. It's better than on-demand therapy. It can be considered as a first step of prophylaxis in some countries, but not the final goals. So with low-dose prophylaxis, we are able to minimize challenges, to offer better care for people with hemophilia coming in from low resources countries. It's optimistic future for this line of therapy. And again, it should consider as the first step of prophylaxis. And if we listen to Manuel Carcao yesterday, now prophylaxis, low-dose prophylaxis, high-dose prophylaxis, intermediate dose prophylaxis, non-factor replacement therapy prophylaxis is the standard of care, and prophylaxis should be considered a standard of care everywhere. It was demonstrated that the benefit is here, and thank you for your attention.
Thank you very much, Professor Gouider. We now have an opportunity to answer questions from the listeners. I've already got a couple of questions here that have already come through. I would appreciate if each of the speakers perhaps could answer each question as we ask them. Let me start off with Professor Blanchette. What is the evidence for subclinical bleeding in index joints of patients with hemophilia? And how important is that subclinical bleeding as a cause of hemophilic arthropathy?
Thank you. As you
Victor?
presented so nicely, yes, thank you. As you presented so nicely, the data from Manko Johnson, where that was clear evidence of some clinical bleeding, We have also confirmed the same in our Canadian long-term study, where MRIs were done on the cohort of boys at about 8 years, and then at end of study, which was about 5 years later, on a number of joints had evidence of bleeding in the joint by imaging, where they had no reported bleeds. So I believe this is very important, and may contribute significantly to some of the failures that we see with the long-term prophylaxis that Professor Oldenburg and others have shown as people live more normal lives with more activity.
Thank you, Victor. This question is to Professor Gouider. The question is there any recommendation for prophylaxis in developing countries, especially in those who are living in the rural setting? What level of prophylaxis should they be going for? In other words, no dose, intermediate dose, or the normal dose?
I think that with prophylaxis we must go step by step. It's okay. We must start it step by step, and we must identify priority according.
Yeah, we seem to be battling a little bit there with the sound interference. Whilst that is being sorted out, and I ask the next question to Professor Klamroth. You've presented the data from the PROPEL study. You'll recall that the Dutch intermediate dose prophylaxis program used in the region of about 2,100 international units per kg, whereas the Swedish Malmo prophylaxis used about 4,000 international units per kilogram. Whereas in the PROPEL study, the consumption of factor VIII is as high as 7,000 international units per kg to achieve a level, obviously, which is much higher at 8 to 12%. Do you think that this is affordable even in a resourced environment such as Germany?
It depends. I think it depends on the country, Johnny. So when I started hemophilia treatment, we did low-dose prophylaxis with cryoprotected. So very low levels of treatment. But over the years, the treatment evolved. And I think the healthcare system in Germany is quite strong. And we now already are able to dose for higher levels to reduce bleeding. But I think what Emna says is very important. The most important point is to do prophylactic treatment, and with whatever dose the system can afford.
Thank you, Robert. Again, we're battling there with the sound, but just back to you, Emna. If you're back online, maybe I could just ask a different question. How important are the disease-specific health-related quality of life in assessing the benefits of low-dose prophylaxis? Emna? Okay, we seem to have lost Emna there. Anyone can answer that question, Victor or Robert? In the context of low-dose prophylaxis, how important are the disease-specific quality of life? What is your impression?
We did in Europe a big study. Go ahead, Victor.
Johnny, in the studies nicely summarized by Emna, they really alluded to an improved quality of life with decreased school absenteeism, decreased hospitalizations, but they were never in the main measured in a robust clinical trial sense using contemporary tools such as the pediatric or chocolate tool in Canada, the European tools. So I think there's great opportunity to build those into future prospective studies to get that data to go to regulatory authorities and funders to get more therapy for all.
Thank you, Victor. Robert, do you want to add comments to that?
Yeah, so in Germany, we did a study, and it was Wolfgang Schramm, nearly 20 years ago, the Eschkol study. They compared different regimens in Europe. And one very important point was that the quality of life in the study in the countries where prophylaxis was a regular treatment was much higher than in the countries where it was still on demand.
Thank you. Yeah, there are other questions that are coming through. Please keep on sending the questions. The one, and I think it's an important question being asked, is we do have a number of outcome research tools that we use for evaluating our patients. And one of those is the Hemophilia Joint Health Score. Should each population be establishing its own, or can this be standardized? Anyone can answer that question? Is it necessary to establish the HJH score per population, or can it be generalized?
From my point of view, it can be generalized. Now, Victor, you're the specialist. Go ahead.
Well, I would say that the Joint Health Expert Working Group of the International Prophylaxis Study Group has evolved, really, the HJHS from the Gilbert score to be able to measure objectively by physical examination the scores in index joints. It's now a validated instrument from age 4 to 18. We're shortly going to introduce adult data in a study that involved adults with hemophilia and adults without hemophilia. So I think the challenge more is in the local centers is having good training of the physical therapists or musculoskeletal experts, so they get experience with using that tool, so we can compare results from different countries, different cohorts, different studies, much like standardization of an INR.
Thank you very much. Welcome back, Emna. Sorry, we lost you there. We'll just move on to the next question, and I think this is a question that often gets asked when we visit some parts of the world. Does prophylaxis result in inhibitor development? Emna, do you want to answer that question? In other words,
yes.
Does prophylaxis cause inhibitor development?
I don't think so. In our experiences, we didn't saw much inhibitor with prophylaxis, and more than maybe giving a risk of prophylaxis. Prophylaxis could be considered, especially if it is started as early as possible, as a kind of induction of immune tolerance. So it should protect on the development of inhibitors, but according to the different now literature, we know that development of inhibitors is there is a multi-risk for development of inhibitors. And I think that in countries with limited resources, we must start it as early as possible with a low-dose prophylaxis in children as soon as possible. This must be the first step, according to me.
Thank you. Anyone else want to add to that, Robert or Victor? If not, I'll move on to the next question, which I think is a very interesting question. It talks about females who've got mild hemophilia. Do they need to have higher trough levels to prevent bleeds, especially if they are active?
I think it will depend on the kind of bleeds they will experience it. Is it gynecologic manifestations? It is joint bleeding? Is it mucocutaneous? I think we must consider this to answer to the question.
So treatment is not only adjusted to trough levels, but it's adjusted to the clinical phenotype too. So the question is, if there is significant bleeding, of course, she needs prophylaxis and higher trough levels. But if there's no bleed, she needs no prophylaxis.
Excellent. We can take perhaps one more question that came through the session here is, practically speaking, if we were to introduce prophylaxis in a resource-constrained setting, how would you go about doing it? For each of the speakers, perhaps to give us your thoughts. Let's start with Victor. If you were to introduce prophylaxis in a resource-constrained environment, how would you go about introducing it?
Well, just one comment from our collaborative work with China. The follow-up paper to Runhui Wu's publication was from Tang and the group, and they attempted low-dose prophylaxis in 15 hemophilia treatment centers, 12 of whom were not able to comply with even a short period of prophylaxis. And it really related to the lack of a comprehensive care nucleus in those settings, because there's great disparity in China as in other countries. I think it is crucial to have the nucleus of a comprehensive care team in place as you introduce low-dose prophylaxis, or it is likely going to fail.
Thank you, Victor. So we need a comprehensive care team. Robert?
I think that's the most important point, because without home treatment, prophylaxis is not possible, because it's not possible to come every second day or 3 times a week to the hospital in factor 8. Second is, there's a very nice study nearly 50 years ago from Klaus Schimpf. And he gave the same dose of factor 8, once weekly, 2 times weekly, 3 times weekly. Yes? And it was 15, in the end it was 15 units per kilogram body weight 3 times weekly. And the results in reduction of bleeds was much better than to give the whole dose once weekly. So, due to the low half-life of factor 8, you have to give it best at least 3 times weekly. And for this, I think home treatment is the first thing you have to achieve if you want to introduce effective prophylaxis in your patients.
Thank you, Robert. So home treatment and adherence to a regular regimen would be important components. Emna?
Yes, I will
How
add
would you introduce low?
I will add to these 2 conditions which are mandatory, that we must choose priority, and we cannot move from nothing to prophylaxis to all people with hemophilia. We have to identify the priority, and we have to start step by step. And by starting step by step, you will increase progressively your consumption of a clotting factor concentrate, and the government can follow you easier than moving from nothing to a high-dose regimen prophylaxis for all people with hemophilia. So priority must be identified. Hemophilia treatment center, multidisciplinary care, home treatment and nurses, it's mandatory to start, and education, education, and education.
Thank you very much. On that high note, I'm afraid we have run out of time for this question and answer session. I would encourage everyone to still send their questions. They will be answered offline. I would like to thank the panelists for taking time to come and share with us your expertise on prophylaxis. Thank you very much.